Okay, we'll get started. Welcome to the Royal College of Physicians of Edinburgh. I'm Peter Rice, I'm Chair of Scottish Health Action on Alcohol Problems, SHAAP, who are delighted to run today's event. Very briefly, we were formed 13 years ago as a project of the medical Royal Colleges in Scotland, so the physicians, psychiatrists, which is my own background, GPs, dentists, surgeons, right across the board, concerned about the harm from alcohol in Scotland and trying to draw attention to that and start to find some solutions to that. Our co-founder Bruce Ritson's here with us today, and it's always great to see Bruce. So that's who we are, and of course that work has taken us into many different areas, and today's launch of our report on lived experience is part of that. Good healthcare always involves an alliance between the practitioners and the people that they're working with, whatever your branch of medicine. So for doctors like me, that ought to be part of what we're doing every day, and taking that, say beyond SHAAP's, if you like, narrow role into a much broader role has led to this work today, and the report, which is in print form at the back there. So great to see you all. Some quick housekeeping things. The toilets are downstairs and the fire exit is out one of those doors and to your right and out into the street if we need to exit the room. This, I think, may be just about the biggest event that we've run. Audiovisually, it's the biggest event we've run. We have 8 people dialing into this event. Mark up the back, who's a seasoned campaigner in these things, is going to help us out. So if we get through the day with the audio visuals working, that'll be great. I think for the people dialing in, if you could keep your buttons on mute, but once we get into the discussion period, if you just unmute your button and tell us you want to speak, we'll speak to you. And we'll be able to hear you but not see you, I think, when we have it have people dialing in. So that's for the discussion phase. This event is being recorded and we'll put it up on our YouTube channel. So we will not be visually recording the audience, but we will be recording audio. So it's best, I think, during the discussion period, if people feel able to identify themselves, I think that's best. But if people don't want to, then that's perfectly fine too. So you'll be on audio, but not video if you contribute, and that will be up on our YouTube channel. So I think time's tight. We've got an important report and a lot of speakers, so we'll move on pretty swiftly. And pleased to introduce our first contributor, who's Nick Smith, who's the National Support Lead for Scottish Government. I was just wondering where you were there, Nick. I'm very pleased to see you stand up there. I thought you'd shot the crow. Anyway, here you are. And I'll hand over the mic to Nick, who's going to take us through the Scottish Government's perspective on this.
Thank you, Peter. Thanks for giving me the opportunity to say a few words. Peter says I work in the Scottish Government in the National Drug and Alcohol Support Team. And we really welcome this report, and just want to say thank you to Eric, to Briege, and to Ruth as well for producing the report, which I think is really helpful for us in thinking through this important area of work and how we involve people with lived and living experience in our approaches to addressing drug and alcohol use. Just because I need to do this everywhere I go, Rights, Respect, Recovery, our strategy to address problem drug and alcohol use, has an 8-point plan within it. I'm sure you're all aware of this. And one of these points is around how we involve people with lived and living experience. So it's an important aspect for us in this strategy. And this strategy, yes, it's published by the Scottish Government, but it's a strategy for Scotland. So this is something that we are taking forward together with Alcohol and Drug Services, those with lived and living experience, Alcohol and Drug Partnerships, and other colleagues and stakeholders across the board. So I just wanted to give a couple of reflections on this area of work, just because I think things have changed quite a lot in the last 10, 15 years for the positive, and sometimes we forget some of that. So I just wanted to pick up on a couple of things, really. One being, certainly 10 years ago, or longer, when I've been working in drug and alcohol services, we used the term service user involvement a lot. And that term has quite significant power dynamic to it. And it's really good to see that we're using terms like involving those with lived and living experience. And I should say actually involving people with lived and living experience. So we're using people first language, which is just such a step forward for us in terms of how we talk about these things, and therefore what happens in practice. Service user involvement suggests that services have the control, which they're passing over to people who use those services. And I think we're seeing a very different dynamic emerging through this report. When we talked about service user involvement 10, 15 years ago, certainly in treatment services, the big question was, have you got a suggestion box? And it's nice to see that we're moving on from thoughts around that and pushing that much further. So instead we talk about things like co-production, which is much more dynamic and has its roots in community development. So very different from the idea of suggestion boxes, which services may or may not take on board. The idea that this is quite complicated, it is quite complicated, but at times I think it led to us not actually doing anything. And instead we're starting to recognize that we need to build capacity within recovery communities amongst people with lived and with living experience to engage in or to be involved in what we're doing. So just recognizing that, I think, is really quite important. And I think as well, we in the past have taken quite a deficit-based approach. We haven't seen the assets that people have. And I think now we're starting to recognize stigma, exclusion, and what that means for us in terms of how we reach out and how we involve people and how we enable people to be involved in what we're trying to do. And clearly having a visible recovery community makes a significant difference for us in terms of it puts pressure on us as those who are working in the field to involve that visible recovery community in what we're doing. So a few reflections for you. But just on the report itself, I think it's really good. I think it highlights, for me when I read it, it highlighted where we've come from and where we're going to. May not have done that intentionally, but for me, that really came through in some of the themes that it picks up on. In terms of recommendations in the report, we need to look at the recommendations in detail. I think we need to be quite brave in what we do next. There's nothing in the recommendations that I think is insurmountable or impossible. We need to take a few risks, but we need to put the safety and well-being of those who we're involving in this work first as we take it forward. So yeah, we need to put those risks and being brave in the right context. And most importantly of all, we need to ensure that colleagues, so this is written, a report, sorry, the report was written, which I don't have with me just now, but was commissioned by I'm just going to hold it up. So the report was commissioned by the Scottish Government and written for the Scottish Government, but we need to make sure that as we take this forward, we're taking forward our colleagues in drug and alcohol partnerships, in treatment services, in the broader services that work and support people with drug and alcohol problems. So I think the recommendations really, that was all I was going to say. So thank you.
Okay, thanks very much, Nick. And I think we appreciate the government's interest in this. There's a lot of good things that have happened in Scotland in alcohol policy and other policy areas over the last few years, and we hope this report will help to move that along. So our next speaker is Michaela Jones, lived experience officer with the Scottish Recovery Consortium. She'll be known to some of you, indeed is waving to some of you as you speak. And Michaela and I got the train through this morning, and I saw her executing her office as a lived experience officer. these fascinating conversations that you fall into with people on trains anyway. She might tell you a bit about that later, but it was good to see her in action on the 11 o'clock Queen Street to Waverley train. And so Michaela's speaking from a recovery perspective, and I think a recoverist's perspective. And without further ado, I'll pass the mic to Michaela.
I don't think I have the mic. I'm sure you can hear me.
I think the people, right, unless you can reach Aberdeen.
Can you hear me in Aberdeen? Okay. I'm just going to say I feel really anxious about this, and I've been anxious for days, and I was trying to work out why. And do you know what it is? This feels so important to me, so vitally important. I suppose first of all, though, I want to say thanks to everyone involved in writing and contributing to this report. It feels to me like a massively important milestone. And in the spirit of a report called Stand Up and Tell You My Story, no, Stand Up and Tell Me Your Story, I'm going to tell you a story. It was a dark and stormy night. Oh, no, not that one, sorry. So once upon a time, there was, I was going to say a girl, but I'll go with woman. There was a woman, and there were lots and lots of good things in her life, but there were also lots and lots and lots of bad things. And that person used substances to make those bad things bearable. And then, as is the way with stories, those substances actually became much, much worse than the bad things themselves. That person went through years and years of denial, and then eventually to acceptance. And with that acceptance came a really strong desire to try and get help. But the response to those requests for help were numerous knockbacks from all parts of the system. Because that person, in a way, was really naive. Like lots of people, that person really thought there was a safety net. Things got worse and worse. The knockbacks continued. And that person tried to commit suicide. The irony was in that denial was actually easier. At the point of accepting the need to change and the help to do that was found to be, and trying to find the help to do that, that's when it became most impossible. That's when that person became most stigmatized. That's when that person got the least help and support, from DWP to housing to treatment. That person was destroyed and angry. That person managed to find recovery despite all the numerous barriers. That person changed their anger into desire to change things. That person was me. But this is a story of a lot of people, a lot of whom don't make it. That's why lived experience matters. I think what we're dealing with is an unresponsive system, not unresponsive people. So I've written this down because it's so important to me. Usually I do it off the cuff, but one of the biggest boosts I experienced in my journey through the system was people who disclosed their lived experience, despite the system saying they couldn't. In some cases, it was a disciplinary offence. The most vital help came from professionals who cared, from professionals who bent the rules, who acted as one human being to another. Because it's not just about people on my side of the glass barrier. Who remembers the glass barriers? I think they still exist in some places. It's not just about us on this side. It's about this, utilising lived experience is about making it better for professionals too. And we all know that our services are full of people with lived experience who are professionals. What a fantastic resource. Because there's no them and us in reality. We've all experienced knockbacks from a system that doesn't work for us. How many people here have been to their GP and walked out going, that's not what I wanted? How many people have taken an elderly parent into a system that seems to deny that person? So we're all experiencing this. We all have lived experience of the pressing social problems that we have. Some of us have particular experience of drug and alcohol as an issue, but we all have experience of dealing with a system that we don't feel listens to us. And we've all had to act professionally in ways that we'd rather not, because what seems to be arbitrary rules, inflexible structures, or I'm sure you reckon it's very hierarchical ways of working. I think that takes its toll on all of us. So it takes its toll on those of us who are trying to get help and support, and it really takes its toll on those giving help and support. I think the hardest thing, but in a way the easiest thing, is for us to accept that things are not working. And while that's not about blame, it will be if we don't use our common humanity to create something that works better for everybody. As the report says, this requires bravery, not just from those of us who tell our stories, but also from those who are listening. I really believe we are brave enough.
Right, you might not be finished yet, Michaela. There was a discussion period to come. So, but thanks for I think just the clarity and focus and that you bring to it and remind us really why we're all here. So we're in the process of setting up the PowerPoints, which are going to be shared, I understand, with our folks dialing in. There's eight different people from around the country, which I think, you know, that tells a story that there's been so much interest. So very pleased to pass on to my friend and colleague now, Eric Carlin, Director of SHAAP, who along as you'll see there with Breach Nugent, and Ruth Molson was the authors of this report.
Join the meeting.
Okay, and I think more than that, Eric really was the moving spirit behind the concept of us needing to do this, and it's I think great to see the print version, and there's one at the back for all of you, actually emerge. So without further ado, I'll pass over to Eric, who I know has some slides to take us through the key points of the report, and then after that we'll move into a discussion period.
Thank you very much, Peter, and thank you, Michaela and Nick, and for all of you for being here. Like Michaela, I'm very anxious because I think this is so important. I'm also really conscious of the limitations of what we've been able to do with this report, and I'm going to explain the purpose of it as being to move things forward in small ways, but by no means suggesting that that we've reached where we ought to be aiming for. It'd be useful if I kept this as well, wouldn't it? So I'm going to just say a little bit about the policy context within which we've undertaken this work, the background and the rationale for it, say something about the methods and the limitations, draw out some key themes from the literature review. One of the themes that we're picking up in SHAAP and using more and more as a term is evidence for advocacy. And I believe that that's what this report does. It provides evidence for advocacy, and that's what we should be doing in all of our work. I'm going to draw on the interview findings about meanings of lived and living experience, what they can say to policymakers and service planners, how to capture narratives and how that brings about change, and then some conclusions and some recommendations. So the policy context is that we have the alcohol framework, which is where SHAAP's mainly been working until now, looking at regulating the market for alcohol, including actions which affect population consumption of alcohol. So looking at price availability and marketing. We've done less on looking at treatment and care and support for recovery. And so we greatly welcomed rights, respect and recovery and the opportunity to be involved in influencing that. What I would say, though, is that although the focus in this report has been on rights, respect and recovery, you know, prevention and recovery are part of the same thing, and we need to integrate all of the actions together rather than thinking that we can concentrate on one part of this or another part of it. We need to be affecting the whole of it. So, and what does rights, respect and recovery say? Nick, you're absolutely right. It does talk about it. It talks about how it can inform approaches. It has the potential to be regarded on the same level as experts. I've deliberately put that in inverted commas. It can support plans to reduce stigma, and also that it can enable children and young people and others who are affected by other people's alcohol and drug use to contribute to developments. But the terms are generally undefined. Through these documents, and this is not a specific criticism of the Scottish Government, it's an overall comment on, I think, where we are in terms of our thinking. Aspiration needs to have some concrete plans to go alongside it, and that's what we've been trying to do with this report. So just to tell you where this came from, it came from a series of discussions with partner agencies, and they're all listed, and I'm really grateful to the national agencies that they wanted to engage in these discussions about, we're talking about lived and living experience, but what can we actually do about it? And so we basically just had a series of meetings, and we just came up with this idea, why don't we do this and see where that gets us to? We recognised that it was a genuine intent by government to engage, and that there were pockets of progress, but there was more to be done. We felt that even among ourselves, there might be inconsistent meanings and understandings of the terms of what we mean by lived and living experience, what we mean by recovery. Even within our own organisations, we thought there might be differences of perspectives on those things. We felt that there was a recognition of the visible recovery movement, and that's great, thanks to the great work that the Scottish Recovery Consortium does. But at the same time, we also felt that the work of other agencies and the contribution that other agencies, such as the fellowships, so the Alcoholics Anonymous, Cocaine Anonymous, Narcotics Anonymous, make to supporting people's recovery, are somehow or other lost in the policy discussion, because we haven't worked out about how we can engage without compromising their traditions. But we decided that we were going to kind of do something. We were going to see if we could gather this evidence for advocacy that I talked about. So what did we do? We did a literature review. So we did a review of what we could find in the literature about meanings of recovery and to answer the questions that we were considering. We undertook 13 semi-structured interviews with 7 organisations with a national focus. They're all listed in the report. We agreed that we wouldn't identify individuals, but that we would identify the organisations. I would say I'm very grateful to people that they engaged with this process so openly and honestly. And there are some risks for people in doing that, because you've only got so many organisations in Scotland, so people might be able to work out where they think that might be coming from. But people did not allow that to inhibit them, I think, in really contributing to an open and honest and constructive discussion. Yeah, the limitations, these are the perspectives of a small number of individuals in organisations. We haven't had engagement in this process with the 12-step fellowships or with people who use services. So that's something that we need to move on from. We had more discussion of alcohol than drugs, and I think that was really because it was SHAAP who really originated the idea, and our focus has been more on alcohol. And I think we reached consensus on meanings and usefulness of the term lived experience, but I don't think that we actually got to that stage with living experience, and so that's something we need to be teasing out further about what we mean by living experience and whether we think that is useful and in what way it's useful, and if that is different from lived experience, in what way is that different. Can I just say my other anxiety is I'm also really conscious of people in the room have all of this experience as well. So I'm kind of really presenting this, and I'm absolutely not pretending that I have anything like the experience that we have shared among us. So my anxiety is about that, but hopefully, I just want you to hear that really. Means be nice in questions. So basically, just from the literature, I'll go through this very quickly. So meanings and value of lived experience. So this is a definition. So it's the experience of people on whom a social issue or a combination of issues has had a direct personal impact. Some of the literature talks about how personal biographies are enmeshed and embedded within society's cultural values. So your experience of alcohol and drug harms are related to how your society sees alcohol and drugs and getting into difficulties, and whose responsibility is to get into difficulties and to get out of difficulties in relation to these things. the ideas about restitution, quest, and chaos intersect. So basically, the idea that that this experience has some kind of meaning, that you're in search of some kind of meaning, or it's just kind of chaotic, kind of through the whole process. They affect people as they live through their experiences, as they live through the recovery, and they're all they might all be happening in different ways at the same time for individuals. So lived and living, they certainly imply this idea of biographical disruption, which is basically the idea that my life was going in that way, and then it went in that way. So that's absolutely kind of central to the definition. But I think that lived implies that there's some kind of optimism in a way that living doesn't necessarily. So lived implies that there's something that you might call heading towards recovery, or being in recovery, or on a recovery journey, or something implied in lived, which is not necessarily implied in the term living. Engaging with this is about engaging with people that builds connections, empathy, and hope, and it reduces stereotyping. So engaging with these with people with these experiences is actually going to kind of achieve these outcomes. Garthwaite talks about this idea of the shared typical, so that actually we actually have far more in common with each other than we have that separates us. This idea of expertise is widened, and we have evolved knowledge from individual and collective agency. We can all take action together. Other people, I think, have heard me talk about that whole communities need to recover. I don't believe that individuals need to recover. So I think we have to be doing that all together. And it's a practical thing. You will have better policy. This is not just for the sake of it. It's not to tick a box to be kind of PC or something. It's actually, we're going to have better policy. We're going to have better practices. We're going to have better services. We're going to, if we engage with these things. Some of the challenges that are identified in the literature are that by identifying people who self-name as having lived experience, you can be involving them in policy discussion and excluding others who don't self-identify, but still may have something useful to contribute. Chen talks about the need to have some kind of distance from experience, that if you're still in the middle of a very traumatic, chaotic experience, how can you usefully contribute to a policy discussion? Just to say, I'm presenting these things as things that are in the literature, and I'm not suggesting that you need to agree or that I agree with them or disagree with them, but this is what the literature says about these ideas. That there are hierarchies of knowledge exist among professionals, and particularly including medics, is highlighted in the literature, with the idea of science being prioritized over lived experience in many contexts. But sometimes people kind of going to the other in the other direction and prioritizing lived experience over science. And this White talk as well about how to protect people in the process of engaging. So we want to engage people with sharing their stories, but these are still people who have got problems or have had problems, and that's how do we make sure we don't just suck them in and use them and say goodbye to them. Overcoming the challenges, valuing different types of evidence. We produced a report called Dying for a Drink, which looked to bring together and to value on the same level stories of lived experience with epidemiological evidence. And that's what I kind of firmly believe we should be doing. To have a public action approach, acknowledging that we have diversity and that we have contested priorities. We're not going to agree on all of these things. We just need to establish processes for working out how we assess and how we make decisions. And there needs to be organizational support, practical and cultural. So that's about kind of, ensuring people have the practical resources to enable them to contribute in a meaningful way, but also that it feels right. Feelings are actually really, really important. We can learn from other health contexts, and particularly in mental health. And Walker talks about a mental health service user is more than just a mental patient, and a service provider is more than just a mental health practitioner. And so recognizing that in this room, there may be people, we may come in here and we may identify ourselves to others with a certain label, but we all carry a load of different labels, and we all have a load of different identities in different contexts. And that goes for whether we have professionals or people with lived experience. Stigma is a really big issue in terms of underrepresenting people with substance use experiences in policy making. That distorts identity, so you become the drug user, or you become the alcoholic. I'm saying that advisedly. I mean that in a negative way. You become the alcoholic or the drunk. Stigma in service, and stigma is actually throughout services, and people feel it, and that's where the culture, affecting the culture of services, is really important. Telling stories overcomes this. One study that we found, which was an investigation with our AA members, talked about how telling stories with each other, with other people, actually helps to overcome that sense of stigma and self-stigma that people experience. And it also opens up new issues for research that actually, if we were just looking at kind of the traditional professionals, we might not identify, and we might not think about the new areas for understanding. I says I'm starting from a perspective where I actually think that anyone who comes to work in addiction services or substance use services wants to make things better. So actually, the point of this is actually, how do we make things better by understanding each other better? So conclusions from the literature review is recognition. There's a recognition of the value of lived experience, but what constitutes it and lived and living experience is ill-defined. But engaging with lived experience can improve services and policy. It can mean that we can promote taking positive risks and doing with rather than for people. And specifically, we can connect people, build empathy and hope, flatten disparities, promote inclusion, encourage innovation, and responsive and reflective policy. And that's all dynamic. So we're not going to have a policy and then we end. It's all a move. It's all going to keep on moving and looking forward. So I'll move on to the interviews. And as I say, I'm deeply grateful to the people who took part in this process, who I think have been very, very honest in terms of sharing their experience and their perspectives. So in terms of what do we mean understand by lived experience, generally people think this is great, that it's a very positive step supported by good intentions to have that placed centrally within rights, respect and recovery. And one person said, we help the Scottish Government elaborate that in a meaningful way. So we're engaged in a process to actually help them work out what to do to make that real. In terms of meanings, some experience of addiction, I mentioned this earlier, and possibly recovery are generally understood to be central to the meaning. So it means people who have experience of being addicted to alcohol or drugs, that they are hopefully in recovery and bringing themselves and their knowledge of how they recover to help others. So this idea of service. But that wasn't necessarily shared by everybody. Somebody else said, recovery itself is poorly defined, and you don't necessarily have to be in what you might call recovery to have lived experience. One of the things that's really important is to hear the missing voice, which is people who are living issues in relation to services, or maybe not in services, because 60% of people aren't accessing the services. So hearing those missing voices, so that we actually change the situation where we've got 2 football teams dying every week because of alcohol issues, and the record number of drug deaths in Scotland is still the situation that we're in, and this is why we want to change that. Some people suggested, though, that it was really important, as well as, and I've deliberately put that in inverted commas as well, extreme experiences of really kind of your biography being really seriously disrupted. It's also important to hear broader communities' views. One person saying, well, I drink and I haven't ever done that, so I don't really understand kind of how you end up. So actually, this person saying, I don't understand that. So, and And somebody else saying people are given extra credibility because of their lived experience, or only they can have a view, and that's not also helpful, because actually we all bring experience, we all bring knowledge and expertise, and there shouldn't be a hierarchy. This is where it becomes quite complicated, because actually, if this person can drink and they drink socially and they don't understand this, can we not find out something from them about how they think they ended up like that? Does that not help us with prevention, as well as hearing the other perspectives as well? And this is the same point on the bottom here. So why can't we invite people across the spectrum of lived experience, or even just members of the public as well? It's interesting you said, or even just members of the public as well, as though they're not. You know, it's quite an interesting perspective. But why don't we speak to people and ask them what they think? Because we're all part of a community. I do kind of share that perspective. So lived experience, it widens the definition of expert. Somebody saying, you know, we have to, and actually these people have fundamental insights that are really valuable to us. Again, you know, there's a bit of me that doesn't quite like these people. And actually we should be thinking about people like us, we should be saying. We asked people, is there an expiry date? We were deliberately challenging. We asked people, is there an expiry date on lived experience? And this person said, I don't think it necessarily have, but it needs to be put into context, and we should be evaluating it for what it is. So if someone can tell us where they are now compared to 20 years ago and how they got there, hopefully that means something's really going right. But at the same time, if somebody's in the middle of a crisis or has just come out of treatment, they'll give us something different. So both of those lived experiences are actually really useful, but how you evaluate them, you need to be paying attention to that context. And weighting it alongside other evidence is also very, very important. All evidence should be treated with value and interrogated just the way that any other evidence is interrogated. We talked, a number of interviewees talked specifically about the Scottish Recovery Consortium and said how useful it was in terms of providing a platform to support the engagement of people with lived experience. However, it was also felt that that the responsibility, not just who you're speaking to, but also putting all the responsibility onto that one organisation or those people is not actually correct or fair. And we need to gather lived experience accounts from different people in different contexts as part of ongoing conversations. None of this is easy. And I know kind of I can see Michaela and Chapter nodding. This is absolutely not saying there's anything, any criticism of the Scottish Recovery Consortium. It's saying about entry routes and where policymakers, if they're serious about this, need to be diverse in their approaches. This is somebody said, so that's part of it. It's not giving it to one organisation to sort of go, right, your lived experience, everybody else is other. And keeping a process of discussion. People who develop policies at government level, they need to be out a lot more. They need to be engaging with all of this stuff all of the time, not just occasionally dipping in. So how do we do it? I think this was an important point that was raised, that actually, well, first of all, you know, people shouldn't feel that they have to out themselves. They shouldn't have to feel that they always have to tell their stories. If you know, people recover in loads of ways. People manage their lives in loads of ways. There shouldn't be any compulsion that if you're engaged in some kind of process that you have to you have to share that with other people. And that should be really a personal and individual choice. This is about professionals. My experience is they fall broadly into two camps. Some people recognise the value of it, and some people are terrified of it. I think that's quite interesting, actually, that sometimes people might think that professionals are resistant. Think about why they might be resistant. Professional, in inverted commas. It might be that that they think, well, I can't ever learn this, and somehow devalues them. So where people think that there are barriers to communication and engagement, it may not be because people want to be like that. It might be because they just need a bit of help and support, in the same way that we're talking about people with lived experience needing help and support in terms of engagement. I really like this one in terms of thinking about scientific rigor, because we have this idea of, you know, lived experience over there, and then we have the real evidence over there, which is the science. This person was saying, you know, and science works in a way that we learn something, we learn models, we learn theories, and then we put them into practice, and then something new comes along. True scientists are able to accept the new information and alter their stance accordingly. That should not be threatening, that is actually about making the science better. This is the way not to do it. This is where we got to stand up and tell me your story from. So when people say they're hearing stories of people in recovery, they mean stand up and tell your story, and we go, that's a very interesting story. Actually, that was quite moving and it's very enlightening. Thank you very much. If you'd just like to leave the room now, and we'll get on with our business. But what happens is these people who have this massive, apparently massive insight, I think that's meant to be sarcastic, are then packed off back to wherever they came from, somewhere in the west of Scotland, and he goes back to St Andrew's House or wherever he works, and you think, what happened? What was the communication there? Who was empowered by that? So that's not how not to do it. So the well-being of individuals is really important. So it's about getting back to these people, the people that were repeatedly put on a pedestal and were asked to share their story. What's that actually doing to people's psyche, and how are they processing what they're happening? So paying attention to people who are involved in the process is vitally important. There needs to be an openness and consistent commitment to the process, including monitoring and evaluating processes and outcomes, including a range of perspectives. It was suggested could actually move our conversation beyond discussion of crisis and towards thinking about how do we prevent problems in the first place. And we talk about humanity. This could open a culture of openness, reduce barriers, and recognise common humanity. This is somebody else's quote. When I go to some of these government civil service things, it says bloody, doesn't it, somewhere? Yeah. The people that I see in this meeting are completely bloody different to the people I know outside of that meeting. I hate to tell you this, but we're all actually human beings. We're all emotional and stuff, and it's not bad. And I think that's probably why we have a lot of issues. It's because of this strange measure of professionalism. So really rethinking all of that, I think, is kind of was central to what people have been suggesting to us. There's a general recognition that those with lived experience are often strong advocates for change, passionate, driven, and doers. It could influence public discourse to question our culture, and this was particularly about alcohol use as a norm within our culture. It can also help us understand and respond to new issues like new psychoactive substances, new ways of marketing illegal drugs. So there's kind of practical stuff there as well as cultural change ideas. People were suggesting a public action approach, so there's an ongoing dialogue. So this is recognising that the civil servant who leads this, Nick? Yeah, the civil servant who's employed to implement the strategy is the person who makes the call on this, but it should be informed by those kinds of interactions that should be going on all the time. And there ought to be some way of making sure you haven't got somebody sitting in St Andrew's House just writing something and not being connected. Ultimately engaging with lived experience in policy making, recognising and prioritising the diversity and complexity of voices and accounts could have revolutionary potential. This is not about changing services, it's about changing our society. And that's about making it better for everybody. I think this is interesting. This isn't about kind of saying, you know, you people with drug and alcohol problems, we're going to solve your problems. We're actually going to try to make our societies better for everybody. We all have potential to have alcohol and drug problems and other problems in our lives, and we actually need to recognise that it's our shared approach that's going to change our whole communities that we should be aiming for. I think as well that lived experience is going to be broad, it's going to be diverse, it's going to challenge, but that's the work, it's the complexity, and we shouldn't shy away from complexity, because unless we engage with it properly, we're never going to come out with something that's actually effective. So this is not a short-term plan. It's a long-term aim. So overall, some conclusions: positive mentions of lived and living experience in government strategies, so we strongly welcome those. The human rights approach is deemed to be purposeful. There's some challenges, including contradictory elements about focus. How do you focus, and who do you include, and how do you include them? There are resource implications, undoubtedly. But the public action approach, recognising diversity, contestation and power is absolutely strongly supported by all of our agencies. And as Michaela says, that requires bravery from those telling stories and those who listen. I'm just going to go on to with my very last slide, which is kind of looking at recommendations. Can I just say in relation to these, we've been very specific in relation to the recommendations in the report for Scottish Government. The purpose of that is to be very clear and precise based on the literature and based on the interview about what we think the key issues that need to be addressed, and making sure that they are addressed in a way that's meaningful and measurable. It doesn't mean that we're necessarily saying it should all be exactly done as is laid out in the report. But we didn't want to have some kind of overall recommendation that government should continue to prioritise lived experience as a central part of its overall alcohol and drug strategy. That isn't what we wanted. We wanted something far more specific. So that's so this is where we've talked about having a meaningful plan with lead officer responsibility, focusing on the issues that we're raising in the report. We've also considered that we think that the agencies, we are national agencies working on these issues, that we should have learned from this process, and we have a responsibility to pick up and do something with it. So we're recommending that we should have a reflect and learn seminar, details to be worked out. We also think it's really important to have this evidence for advocacy, and we're suggesting that the Scottish Alcohol Research Network and the Scottish Drug Research Network or other appropriate research bodies should be tasked with identifying priorities, to clarify issues, to synthesize evidence, and also, I think, really importantly, to take this forward, to do some more work in terms of finding out more from people with lived and or living experience in relation to how to engage them in policy. And finally, at a local level, alcohol and drug partnerships should be encouraged and supported to embed engagement through their systems, and they should be measured on that as well. They should demonstrate in their annual reports not just what they've done, but also what's changed as a result of what they've done. So that's a lot. I'm really conscious. I just want to thank again Dr. Breeze Nugent and Ruth Molson, the research participants, the Scottish Government for supporting the work, and thank you all for coming, and let's continue the discussion.
Okay, thanks very much, Eric. So we have about half an hour for discussion. I'm mindful of our people who are phoning in. So if you want to speak to us, unmute your software and shout into whatever microphone you have, and we'll be able to hear from you. So I think you'll be hearing us but not seeing us, Mark. Is that correct? Yeah. Okay, and we have a roving mic somewhere. Yep, Jackie's got that. Okay, so let's just move straight into a discussion period. I was saying earlier, if you want to identify yourselves, that's great. If you decide not to, and it is being recorded and it's going to be up on YouTube, if you don't want to identify yourself, that's perfectly fine. So let's just move ahead. Yep, first point here.
Hi, David Williams from Edinburgh ADP. I wanted to just pick up on recommendation 3 and the role of research or the research networks around this. A lot of the stuff that's being discussed is effectively a research challenge. It's about systematically gathering the voices of people with lived and living experience in such a way that it'll meaningfully inform what you do. And I'd have to admit, I mean, in general, I think most ADPs and probably other people's efforts is a coalition of the people who are willing to turn up rather than a very systematic attempt to go and find people. And the people analysing that evidence know that. So we know that we have a finite range of opinions. to do that systematically, if we wanted to know what the experience of being a drug user using the DWP is, I'll do that quite badly sitting in Edinburgh ADP, but the research networks could do that very systematically, and they could come back with vivid, qualitative data, because I think that's essentially what we're talking about. We're talking about qualitative descriptions of people's experience. So although, I mean, as an ADP, we do some really good stuff around this, I think, and I think other people do too. I wondered if somebody could expand on where the national research effort was going to be, because that, I just think it'd be useful to know how that might come down.
Okay, Eric, I'll let you deal with that.
Yeah, Derek, that's really helpful. I completely agree with you. I think that telling the stories of people's real engagement or disengagement with kind of services that affect their daily lives is really important. What we're proposing here is that the national networks establish a plan, and I would expect that we would engage with people, with all of these agencies, but also with people with lived experience in terms of working out what that plan should be. But engagement with DWP just seems such an obvious one. I couldn't agree with you more.
Thank you. Jordan Simpson from the Scottish Recovery Consortium. I really welcome what you said there, David, in response to that recommendation about research, but the need for clarification of it as well. But if I can go a bit further than that, by using your very example, you know, the DWP recognised that it itself has an issue with how people who are using drugs or have used substances are treated within its systems. And as a result of not only consultation and research to lived experience, but also by the inclusion of lived experience staff of the DWP. The DWP have taken a step of, in Scotland, creating a national addictions and recovery strategy. So the point I'm making here is, in terms of research, people with lived experience do encounter, this is all well and good. We are informed by what you say, but we are busy making decisions here, and we will use that information. That is valuable, to have that consultative role and to feed into decision making in that sense. Who better to lead system change though? Who better to be involved in quality improvement than people who have direct experience of how that system operates, working in tandem with learned and other areas of expertise done in an equal footing. So we need more research, and I really welcome this piece of work as being Scottish evidence around lived experience, because for the last dozen years, as a person with lived experience, and my living experience for the last decade being working in this sector, I have experienced, probably on a monthly basis, when I come up with my fantastic ideas, being told that it's not evidence-based. It should be evidence-based. If I or other people with lived experience are coming up with interesting ideas, but all too often until now, we have, as a society, not lived experience people, we suffered or been excluded from how we can improve how we respond to vulnerable people in our society. That's why I'm really excited by this.
Okay, thanks, Jordan. Michaela.
I was at an event a few weeks ago, or maybe last year, can't remember, but someone came up with the phrase, at the moment what we have is policy-based evidence, and I think lived experience is about moving to evidence-based policy, and it is challenging. But I agree completely with Jardine, you know, and we've had a conversation with Eric, you know, there's a lot of grey literature out there which isn't given the same value, but it's evidence. And I think that's a challenge to all of us. We can continue doing the same things and find things to support that. But that shouldn't, what happens with that is it stops us looking at doing new things and providing the evidence to do that. So for me, lived experience is very much a call for evidence-based policy as opposed to, as I said, policy-based evidence.
Hi, Shamila Ahmed, Managing Director of Resilience Learning Partnership. I suppose my question could be answered by yourself, Eric, or our friend from Scottish Government that's here is, what are the plans to put this out wider, this research and this approach to policy areas using lived experience to inform them? Thinking of mental health, the criminal justice system, our care, young people who are in care. What are the plans to start making this a real area for researchers to get on board who are willing to do pieces of work like you've just done, Eric, and open it up to wider policy areas in Scotland?
I have to say, I don't know. I mean, certainly, this has been a very small piece of work. And that's the other thing I want to just kind of qualify kind of what we've actually done. I think that we've raised some important issues, but I think it's really kind of, it's really a starting point in terms of actually even thinking through some of these issues in relation to alcohol and drugs. There has been more work done in relation to mental health, in relation to lived experience of mental health issues. But I'm not in a position to say what the government plans are. I don't know. Is Nick? No?
Not really. I can say in some of this work, we've done a bit of work trying to define some terms here and trying to define co-production, and we haven't got to a point where we're rolling this out or testing the definition. It's been small scale, and we're now working up to get that out there. But in that work, we've been thinking, well, this isn't about co-production for improving drug and alcohol services. It's about co-production on improving services used by people with drug and alcohol problems. So we had an event where we had people from the Scottish Government who worked in justice and mental health and other parts of policy areas. So the way that we are engaging from the drug and alcohol team in the Scottish Government is thinking, well, what are the other services that are used frequently by people with drug and alcohol problems, and how do we start to influence those parts of government so they respond better to the needs of that group? I'm not sure of plans that across government for this kind of work, I'm afraid.
Hi, thank you, Eric, for the presentation. I'm a retired healthcare professional and a recovering alcoholic of 10 years sobriety. And the field I work in is as a health liaison officer. And I have firsthand experience of the lived experience in the workplace. We organized open meeting workshops for clergy. That was about 2.5 years ago. And we've held 2 for medical practices. And the outcome of those were, as you said in your report, to destigmatize the alcoholic. And it was quite rewarding to see the response that we had from these people. You could say, I have a living experience of these events. The clergy was the first one we ever held. And the email that I got thanking me for organizing it said that anybody walking into that room would not have known who the clergy or the alcoholics were. And then the second one, which was to a medical practice with 26 members of staff there, the leading clinician came up to me and said, we will now regard the patient attending with an alcohol problem completely differently from the way we have in the past, because they understood from our lived experience, what they'd been missing. And it is a very powerful tool when it comes to raising awareness of Alcoholics Anonymous. Thank you.
Okay, thanks very much. Couple here. If anybody from who's dialing in wants to contribute, just hit your button and give us a wave and give us a shout, and we'll get to you. But yeah, a couple of people, lady in the green.
I'm not very good with these things. My name's Deborah Nelson. I work for Redaction in Argyll and Bute. and I am a community engagement coordinator. That's my title. And I think one of the things that struck me as Eric was speaking was looking at definitions. It was almost like, what does it feel like for somebody going into a service? And I think one of the definitions for me that might be useful to look at is the definition of professional. Because I think for me, professionalism, and I've been around the block a couple of times and I've worked in a number of human services. And when I started initially training as a nurse, professionalism was keeping that distance, not mixing your own emotions with the other person. Now, I'm not saying it's in bed as it was in the late 70s, but certainly today in 2020, what we expect of what we give parameters to people when they're working with people. So professionalism to me seems to be being accountable, which we all need to be. Means not sharing too much of your own stuff, because that sort of blurs the boundaries. And I think for me then, that's a massive question we need to be looking. What do we want from professionals? What people here seem to be saying, we just want some human beings. We don't want somebody sitting there. I mean, I'm in the organisation I'm working for currently, we're looking is how can we trail down some of that paperwork? Why are we asking the same question over and over again? So we can score it and risk assess it. So I think for me, in terms of the research, I really would like to sort of see, what do our frontline practitioners see that the name professional as being, and can we widen some of the, I mean, I'm somebody who's always taking a bit of a chance. I always think I'm always on the verge of getting the sack, because I feel like I extend my boundaries quite a lot sometimes, but not to put my own undealt with things to another person, but sometimes it can be just very sort of connected to say, I've sort of experienced something similar, I'm not crying over it. But I think the word professional, I digress as usual, but the word professional for me is something that really needs some definition. Because I think sometimes I have come across professionals who really are really quite either knowingly or unknowingly being quite cold and want to hold the power. And I think that's not somebody's fault who comes into a service wanting to be good if they're told that professionalism is keeping a distance and not getting too involved.
Okay, yeah, thanks. And you know, just to reflect on that a bit personally from my own practice, I think Justine up at the back is our next Jackie. When getting our priorities right came in, and getting it right for every child, we had to, at the end of every assessment appointment, you had to know the name, date of birth, and the school that person's children attended. So they kind of come in for the first appointment. You would ask an open question about, tell them what it was that was worrying you, brought you along here, and they would then talk for, people might talk for however long they wanted. But at some point you'd say, now, could you just tell me the names of your children, the date of birth and what school they went to? You know, now that was for me a problem, a barrier, but that was a system. And Michaela spoke earlier about the systems that people work within. Nobody's going to argue that getting our priorities right is not a good thing, that child protection isn't important. But some of the imperatives that came with that, I think, then became a real burden. And people say, well, why are you asking me, you know, the age of my children? Oh, well, we just need to know. So, you know, I think that for me was an example of exactly what you're saying, that as a worker, you work within a system and there are some things that come along because, well, what if something goes wrong and you didn't find out who the kids were? That's not going to look very good in the inquiry, is it? You know, so, but so absolutely take that point. But for workers, there are, you know, a whole number of pressures on them aside from the pressure that I think most of them have of, you know, wanting to do a good job, you know, alongside the person who's in front of them. Anyway, Justina.
Hi, I'm Justina Murray from Scottish Families Affected by Alcohol and Drugs. First of all, thanks to Eric and Briege and Ruth for opening the can of worms that is lived experience. And I think it's a really interesting report, raises a lot of issues, a lot of questions. I suppose for me, the bit I'm left with is just really reflecting on how lived experience, which is supposed to be a really inclusive approach, has actually felt at times quite exclusive and even quite divisive. And even reading this today and being here today, I really feel we're talking about a group of people with lived and living experience, and actually I can't see families really anywhere within that. And I know that wasn't the intention, and certainly in the conversations, families and wider communities, as we've heard, were mentioned. But there's something there about who we think has got a valid lived experience, and whose lived experience should be influencing policy. So from my point of view, maybe unsurprisingly, working for Scottish Families, I'm going to reflect on that, but also maybe following on from Deborah's point is about frontline workers as well. And, you know, we can be critical of services. We spend a lot of time criticising services, but actually frontline workers have got a lived experience of also being quite disempowered, often working in really quite negative and harmful cultures. And there's something about, you know, I don't think we're there yet in terms of making lived experience really inclusive and, you know, looking at those human connections. It still feels just a little bit them and us, and a little bit divisive. And I know that wasn't the intention of the report. It's definitely to open the debate, but that's just my reflection today.
Can I, Justina, thanks. Just to say, yeah, you're right, that wasn't the intention of the report, and I hope that isn't how it's come across. Just to say, I didn't read out the whole of recommendation 1. There is a point there which says including the plan a strategy across all areas of government. So that's not just health services, and it's not just criminal justice services, it's all areas of government, for gathering input from the wider population, including families, people who may be affected by drug or alcohol use, their own or others, but are not in recovery, as well as young people. So that inclusiveness is absolutely there in terms of the recommendations to be picked up and worked with government.
Okay, thanks. Yep. Yeah,
Thank you. I'm not very good at these things either.
You're coming
First
over
of all,
loud and clear.
how do you do? My name is Jo, and I am here with Al-Anon Family Groups. I'm a member of Al-Anon Family Groups. Thank you, Eric, for your presentation. I've met Eric before. I would like to say what, as Justina said, that lived and living experience of somebody with an addiction, the lived and living experience of somebody living and loving somebody with a problem of addiction is so intertwined. I certainly find in my own experience listening to lived and living experiences incredibly powerful. And it gave me that identification and understanding of my situation. And I think this is where this report is so important, because I often hear in meetings around northeast of Scotland that we are experts by our experience. And it's very easy to say, oh yes, it must be awful, or I understand. But unless you're actually in the situation, you can't understand. And I think this project, to start this discussion of giving validity to the person who either has a problem or lives with a problem, whether they're still in the problem or not, is just incredible. So I would just like to thank you very much. And I would like to, I haven't read it properly, but so I had missed that bit, Eric, about the families being mentioned, but I do hope that we are kept in the loop. And thank you for letting me come today. Thank you.
Okay, pleasure, and thanks for those kind comments on the work, which I can accept because I didn't have much to do with it myself, other than being very pleased to be part of the organisation that produced it. Charles.
Thank you, Peter. Charles Steele, Scottish Recovery Consortium. I'm really looking forward to getting home and get my teeth into this one. It's been, I think, very enlightening in many ways, the different aspects of this topic that are being taken on board here. I love the term revolutionary potential. I really do. I think that's a wonderful insight, because I think that's what's happening. And sort of referring back to what you said earlier, Peter, having been involved from the early doors of what was happening at a national level with the Scottish Ministerial Advisory Committee, where this conversation could never have taken place. With the incremental growth and development, the work of SHAAP and others who have built upon it, the inputs of the fellowships on an anonymous basis, certainly in Edinburgh, the ADP, I'm more aware of what's happening. Absolutely phenomenal to come to this place. I think the two things that really sort of jump out to me is, with relation to the interviews, having been in recovery for quite a while, I know that you can get very different perceptions, obviously, from people in early recovery and people in long-term recovery who've gone through an incremental growth in their experience, the perceptions that they have, which I think, you know, really needs to be balanced in all the work that is done. The other one that really sort of touched me is, I think the term that was used there, people who might be a bit crass, but get captured in early recovery and get put on a pedestal and then get taken in to speak the voice of lived experience and recovery. And I think that's fine to do that on an individual basis, but if perhaps that's being understood by others who think that this is the benchmark for where people are in recovery, it can be very misleading and I would say very damaging. I have seen the fallout of people who have been asked to engage, and rightly so, you know, doing peer support, etc. But I think there's got to be a responsibility within the professional community to be sensitive, engage where their sharing of their experience, their journey is appropriate. And I think that brings in that whole level of sensitivity of working between the professional community, the other agencies and the fellowships. There's so much available here, but yeah, I think we've got to be very sensible about how we take that forward.
Yeah, and it's interesting that latter point seems to be a kind of idea whose time has come. Some people may have seen the piece that Karen McCluskey, Chief Executive of Community Justice Scotland, wrote in the Scotsman last week about just this. I think she actually used the term exploitative, that, you know, of putting, you know, some people out with lived experience and, you know, expecting them to kind of spill the beans in a way that ultimately isn't good for them and helpful for other people. So it's anybody who's not read that, I'd commend you to have a look at that. And it was interesting coming from, you know, a separate sector. She recognised the risks of this in her, you know, criminal justice work and the violence prevention work that she's involved in. Okay, any other points yet?
Yes, Nigel Dow, representing Quaker Action on Alcohol and Drugs, Quad. I just want to pick up on what Eric said. I welcome the fact that you said the recommendation included families in the community and so on. And earlier, I think you talked about there is a sense of lived experience, including the general public. But I think my slight concern was by putting it in this way, just including a family, doesn't recognize that those immediately affected in the family or partnership or whatever, perhaps their experience is maybe not quite as important as those of the actual people suffering them primarily. And then it has a kind of priority over the general public or the wider community. And it seems to me maybe more attention can be paid to those experiences, those immediately around people suffering.
Absolutely, right, gentleman at the back there.
Hello, everyone. Tom Bennett from Forth Valley Recovery Community. I'd just like to add into the discussion today the kind of great work that recovery communities are doing across Scotland today, and the way that recovery communities, such as the one that I helped to develop in Forth Valley, are helping to challenge the stigma, and the way that lived experience is being incorporated into the professional teams, whether it be in the recovery development team that I lead or treatment services across Forth Valley. And what that's doing is helping to change attitudes dramatically in terms of levels of hope and just breaking down prejudices and preconceptions about what and whom people in recovery may be. And I myself speak as somebody with approximately 10 years of recovery from addiction. So I think what I would like to say is that within this conversation, we need to look at how we support recovery communities. You know, you look at what we have in Forth Valley, it's been such a fantastic project headed up. I might name drop Jarden Simpson, who's my predecessor in the position, did fantastic work. And what we have there is an area of best practice in Forth Valley, and it costs peanuts to support. but the funding is so insecure at the minute that I think we really need to look at this in terms of national policy and see how can we support local projects on a kind of grassroots level that are doing such fantastic work, working in parallel with services. And the team that I lead all have lived experience of addiction and recovery. And what we're doing there is we're integrating and breaking down the barriers of, as Deborah was talking about, professionalism and lived experience. And I think that's got to be a part of the conversation that we're taking forward from here today. Thanks very much.
Yeah, and it's great. I guess one of the things that's changed is that now, you know, more is heard about these activities. 20, 25 years ago, there's an enormous amount, still is, of recovery activity going on that was, you know, under the radar. And I think, I can't remember what term Eric used, but, you know, invisible might be a term that used from the, you know, from the long established fellowships. And that's been, I think, a really interesting change and very important change towards the visibility. Anyway, so just about finished off. Any last points people want to make?
Thank you. My name's Anne-Marie Quigg, a Scottish Recovery Consortium and Recovery Movement Officer. So I think for me, what I'm bringing from this is well done, guys. First of all, it's fantastic. And I loved that the recommendations were so specific. I think that's what we need. I think having worked nationally for 10 years in the consortium and being 29 years in long-term recovery, Scotland's a very small place and we should start to pull together national recovery outcomes and measuring tools. Instead of measuring, we need to know, you know, people die, but also thousands of people get better. We don't know how many people, come off methadone. We've got to start measuring in a different way. But if we rolled it out, if Scottish Government rolled it out sort of nationally, this is what our expectations are, then it's easier for frontline services to pick up rather than trying to reinvent the wheel and do it themselves with all the different models. Because all you're getting is a snapshot when the Christos measuring tool, 3, 6, 9, 12. It doesn't actually tell you that recovery journey and all the good things that happened in the up to the first 3 months. So I would love a national directive from the government to come from this getting driven forward. But well done. The report's great. Thank you.
Okay, thanks very much, Anne-Marie. Yeah, maybe we could start with just somebody standing with a stopwatch at recovery walks, seeing how long it takes for the queue to you know, for the line of people participating, because that's a very striking thing, you know, when you see it. But yes, you're absolutely right that we you know, we need to be looking at a broad range of measures, and hopefully the reports will help take that forward. Okay, so we're just about to finish. Our folks beaming in. Anything you want to contribute, or you've been? If we don't hear from you, we'll take it you've been happy with what you've heard. And thanks very much for the contribution, and thanks to Mark for making it all work from the IT department here at the college. Okay, so well, thanks everyone. It's been a great afternoon. This, I think, is one of the biggest events that we've had with SHAAP. So I think it just shows the importance of this report and the way that it's captured people's interest. So we're very grateful to you coming along. I hope we've done something as an organisation to you know, move this process along a bit, and that's what it's going to be. It's going to be a kind of continual process of moving things ahead. So thanks to our speakers, to Nick, to Michaela, to Eric. Thanks to everybody who participated, and to the other authors, and thanks to you all for coming, for your interest in this piece of work. Okay, thanks very much.